Our next speaker is Dr. Blaire Brewerton. He's an addiction medicine specialist at THU, and the topic is the impact of a pilot supervised alcohol provision program in homeless First Nations Australians with alcohol use disorder within metropolitan Adelaide as an intervention to maintain ongoing engagement in healthcare, a retrospective cohort study. Welcome.
Thank you. Good afternoon, everyone. It's a very long title. I'm Blaire. I'm an addiction medicine specialist from Australia. And this research, it was looking at a pilot managed alcohol program targeting Indigenous Australians who had co-occurring homelessness as well as alcohol use disorder. I'd first like to just acknowledge that the research was undertaken on the land of the Kaurna people, and I'd like to acknowledge that they are the traditional owners of the land, and I respect the elders of the past, present and emerging. I'd also like to acknowledge the clients that were part of the program, and I recognise how important their voices are and their own individual stories. So, for those who are experiencing homelessness, alcohol use, unfortunately, is very common, and there's very complex interactions and often quite cyclical interactions between these two co-occurring issues, and they perpetuate each other, leading to significant disadvantage. And as part of this, then, significant associated morbidity, including significant infections, significant mental health complications, as well as significant violence and associated then mortality. Most models focus on abstinence first, and there's lots of evidence showing that abstinence in this cohort is neither desired nor realistic, and as such, there's quite often significant disengagement in healthcare and lots of distrust in both the healthcare as well as social support systems. So it makes it very difficult to then intervene and try and help break the cycle and make meaningful change. And there is growing evidence that managed alcohol programs are an effective alternative harm reduction strategy to address these co-occurring issues. For Indigenous Australians, they experience a significantly greater burden of disease than non-Indigenous Australians, with alcohol as the second largest contributing factor, and they also have a disproportionately high rate of homelessness, as well as overrepresentation in judicial systems, and this is due to alcohol and other drugs. The underlying cause is due to ongoing intergenerational trauma that has been as a result of colonisation and mistreatment by Australian governments in the past, and as such it's even more challenging to engage these clients in care. And as such, there's very limited actual research into managed alcohol programs in Indigenous Australians with these two co-occurring issues. So we had a program in South Australia back in 2023 that lasted 3 months, where patients were admitted to the program voluntarily for 3 weeks, where they received culturally sensitive and safe multidisciplinary care focused on stabilising their alcohol use, managing their acute medical mental health conditions, as well as then stabilising their acute social situations and finding longer-term residential accommodation, as well as re-engagement with their communities and kinship. And this is whilst there was provision of alcohol in a metered way that would prevent them from withdrawing from alcohol and then disengaging, but also preventing them from becoming intoxicated and the harms associated. So this study is looking at, from this program, what was the effect essentially on engaging in healthcare. There were 22 clients in total, with a predominance of female clients. Overall, there were 30 admissions, so people had the option to self-discharge, but quite interestingly, several clients that did self-discharge then later re-presented and were then readmitted and actually completed a full admission and then actually went on to have safe accommodation on discharge. The most significant finding was that there was a quite significant reduction in emergency department presentations. So for 22 clients, 12 months before the program, there was 328 presentations to the emergency department, and there was a 45.7% reduction 12 months post-program to 178 presentations. There was also an increase in engagement with other specialist services that was statistically significant, but there was not a statistically significant change in hospitalisations and AOD engagement. Interestingly, the data was actually broken down to 3, 6, as well as 12 months, and notably at 3 months across all data sets, there were significant changes, but they were not sustained, unfortunately. We also looked at the causes of presentations to the emergency departments as well as hospitalisations, and unsurprisingly, it was mostly due to alcohol and homelessness, and there was not a proportional change post-program, which meant that the ongoing issue for these clients remained alcohol use and homelessness. So notably, there are limitations to this study in that it is a small sample size, so it does limit the power, and this clientele are quite transient, and so they may transit out of the state to other states of Australia, and this study relied on access to the public health electronic records for South Australia only, so we may not have captured presentations that were in other states. But what this means overall, essentially, is that a managed alcohol program may be an effective way to engage this very vulnerable, very difficult to engage cohort to make meaningful changes, with the biggest limitation was that it was probably too short a program, and that the benefits are most likely to be seen if this program was a lot longer residential program. Thank you.